My goal in life is to reduce cost and improve quality in America's poorest city in the healthcare system. And I spent years in this office seeing children, adults delivering babies. I speak Spanish and running from room to room to room seeing patients. And this office is currently boarded up, closed, and I'm not in this office anymore because the Medicaid rates in the US and in New Jersey kept falling to the point that I was being paid $19 to $25 for a visit. So I'm going to tell you about my journey through the city of Camden and trying to disrupt healthcare. It started from being overwhelmed in Camden by the level of violence. It's one of the most dangerous cities in the country, and had a personal experience of someone being shot around the corner from where I lived. I also lived in the city as well, and an enormous amount of violence that I was seeing inflicted upon my patients. I got involved in trying to reform the police department. There was an Attorney General commission to oversee the police department and try and fix it. And they brought a lot of people in from New York who had been part of the reform under Bratton, Commissioner Bratton in New York. And as I learned about Bratton's ComStat model, about hotspotting, about the management changes that went on within the New York Police Department, really began to feel like there were a lot of things in failures in policing that were similar to failures in healthcare. Eventually, I tried as hard as I could to work on fixing the police department in Camden, but threw my hands up and gave up, and went back to healthcare and dove deeply into my own field and took a lot of those ideas with me. Before I talk about what we did, I want to give you a little sense of what's going on in America and our healthcare delivery system. We currently spend twice as much as any other country on healthcare. We cover fewer people than those countries do. The bulk of the federal debt in our country is going forward is due to healthcare. It's due to my industry. This is a curve of the long-term federal debt from 2010 to 2080. The light blue is Medicare, Medicaid, which are our publicly funded programs for elderly and poor, and the Children's Health Insurance Program, the exchange subsidies. So Social Security is not the problem for the long-term federal debt. It's healthcare, healthcare, and healthcare. This is a study called the Dartmouth Atlas, which is an attempt to look for Medicare patients in the last 2 years of life, which is the most expensive portion of Medicare, across all 50 states. So what you find out in my state, New Jersey, we spend $39,000 per Medicare recipient. These are people over 65 in the last 2 years of life. What I want you to notice is that there's enormous variation across the country in what we spend. In some cases, almost twofold variation. New York City, Philadelphia, Los Angeles, Eastern Seaboard are very expensive places in healthcare. Now, healthcare is supposed to be scientifically driven, an evidence-based field. It turns out that it's not. It's not an evidence-based field at all. If you're a pneumonia patient and you walk in the door of any hospital in the country, the likelihood of being admitted to the hospital, the number of specialists that come to your bedside, the medication that they choose for you, are different from place to place to place, and has more to do with the culture of the physicians and the medical system within that community. It also turns out that if you want to know how many people are admitted to a hospital in New York City, don't count up the number of sick people, count up the number of hospital beds, that the supply of services will predict the demand. If you want to know how many people saw a cardiologist last year in Philadelphia, don't count up the number of heart failure patients, count up the number of cardiologists in the city. So there's, as much as we try in healthcare to make a market out of healthcare, it's a very asymmetric, very imperfect marketplace. And the supply of services in many instances drives demand. The other part of this that's very important is that Medicare has a fee schedule that's a national fee schedule, more or less. And it, many years ago, made a decision that they were going to set a very high price if you cut, scan, zap, or hospitalize a patient, and a very low price if you talk to them. So the reason that your doctor is running out the door as you're trying to talk to them is because they're paid very little money for talking to you. They're paid a lot more if they can cut, scan, zap, or hospitalize you. This fee schedule is essentially the fee schedule that all fee schedules across the country in which doctors and hospitals are paid is based on fundamentally. So the problem with that fee schedule is that it's driving more and more hospitalization, more procedures, more scanning, and perturbing, if you will, the marketplace of delivery. This is a very famous study looking at arthroscopy, which is a bread and butter procedure where a 50-year-old will have chronic pain in their knee for a couple of months. They'll have swelling in their knee. They'll go into their doctor. They'll have fluid on the knee, they'll get an x-ray, an MRI, and then sent to an orthopedist. Orthopedist will take fluid out, maybe inject the knee. Eventually, they do a surgery where they put a scope in and do a trim job on the meniscus. They finally did a randomized controlled trial to figure out if this worked. And they did what's called a sham arthroscopy. They put the scope in and just took it back out. And you woke up with a Band-Aid on your knee and you didn't know which group you were in. Turns out they got better at the exact same rate. We do 650,000 arthroscopies. There are a lot of mortgages being paid, kids sent to private school in New York and other communities because of essentially doing unnecessary things to your parents and your grandparents, to Medicare patients all over the country. It turns out that this is true for lots and lots of things we do. And what happened is we set a really high price for this procedure, and everyone wants to do it because you can make a lot of money doing this. And what we did is we ran out of sick people. There just weren't enough people that needed this. So we put up billboards, and that wasn't enough. We put up more ads, and that wasn't enough. We tried to drive demand. And then doctors and hospitals worked down the continuum to less and less sick people over time. We take brilliant technology, and we begin to misapply it. And this is true for lots and lots of things that we do in healthcare. I want to talk about Camden data now and bring this to a local setting. I managed to get claims data. This is hospital claims data. This is billing data from 3 local hospitals. This is their business intelligence. They don't give this data up very easily. It was a huge task to get this data. Combined it all into one data set so that if Jose Rodriguez went to Cooper, Lords, and Virtua all on the same day, I could match them across the data sets. We pretty quickly learned that half the population goes to an ER hospital in 1 year, that someone actually went 324 times in 5 years, someone went 113 times in 1 year. Up in Trenton, someone went 450 times in 1 year. That's so far the leading high utilizer in the whole country. The total revenue, this is payments to the 3 hospitals just for ER and hospital care over a 5-year period, was $460 million plus $200 million in charity care. We did not spend $600 million in Camden of public money well. We wasted money. Good doctors and good hospitals all over America go to work every day and deliver disorganized and fragmented healthcare services. Many of you won't know this until one day when you or a loved one are admitted to the hospital and they're lying in the bed and you're sitting next to them, and in and out of the room come one doctor after another doctor, and it dawns on you that none of them are talking to one another, that you actually know more about your loved one's care than any of those doctors. And it's because they're each dropping an individual bill. They're delivering fragments of care because they're paid in a fee-for-service model. Once again, if you run out of the room or you cut, scan, or zap, you make much more than if you stop and talk to someone. And the problem with that model of healthcare is that it works if you're the average patient, but as you become an outlier in the system, as you get sicker, the system doesn't work well for you. I made a lot more money if I ran from room to room to room treating head colds than when I walked into a room with a really sick patient. All the greatest moments in my career are the extra 5 minutes I spent in a room. It's the extra moment when I picked up a phone and called someone about their abnormal mammogram and it's 7:30 at night. It's the extra work that doctors do to coordinate care. All of that is unpaid work, and that's why it doesn't happen. The most expensive patient in Camden was a Medicare patient with $3.5 million in payments. That's one person. 30% of the costs go to 1% of the patients, 80% of the cost to 13% of the patients, and 90% to 20% of the patients. That's true in every bucket I've looked at. This is true for union patients, commercially insured patients, older patients, younger patients. A small sliver of people that are sick are being ignored in healthcare because the doctors are running from room to room to room and not paying attention to them. The top emergency room diagnosis over a 5.5-year period was head colds in Camden. There were 12,000 visits for head colds, 7,000 visits for ear infection, 7 for viral infections, 6 for sore throat, 5 for asthma, 5 for stomach virus. These are all primary care problems. Most of these patients are insured. They have Medicaid cards. We're about to give out a lot more Medicaid cards in our country. So we're about to give out 15,000 new Medicaid cards in Camden, and the existing patients are not getting good service. So we're about to overrun our healthcare system in America with more people. These are basically poor moms and kids sitting in emergency rooms with Medicaid cards waiting 6 hours to get treated for primary care because they couldn't get in to see a primary care provider. In the city of Camden during my time, hospitals have built new wings for $500 million. We've tripled the size of the emergency rooms, and primary care offices like mine are going out of business. This is really a metaphor for what's happening all over the country, which is because of the Medicare fee schedule, we're paying way too much money for hospitals and not enough money for primary care, which is distorting the supply of services and the distribution of services. This is doing a map of all of the cost in the city of Camden for hospital and ER care from all 3 hospitals over a 5-year period. Very hard data to assemble. This is looking at what's called a census block, which is a very small geography. The map of the city of Camden, the red areas are 6% of the city blocks, 10% of the land mass, 18% of the patients, but 27% of the visits and 37% of the receipts. So not surprisingly, expensive, complex people live in towers. They are older, disabled people. And the building at the top is called Northgate 2. 600 people over 5 years had $12 million in payments for their care. And that's only counting the hospital and the ER care. Abigail House had 300 patients with $15 million in receipts. These are both beautiful buildings with great management. This is a story about dysfunctional, disorganized healthcare. There's a major academic health center 6 blocks away. It could be 600 miles away. We've spent about a year doing community organizing in the top building, and the stories are terrible. I mean, I'm deeply embarrassed by the quality of care that patients in this building are getting. We have to bring care to these patients and not move them around. 10,000 people every day turn 65. We have 85 million baby boomers headed like a freight train down the tracks to our delivery system. No idea how to reduce cost. We pay twice as much as every other country. We have a cataclysmic problem, and we have made the world's largest economic bubble, far larger than the housing industry. Healthcare is 18% of our economy. It will become 25% of our economy. So we have a bubble of hospital beds, of cardiologists, of orthopedists, of capacity within the delivery system that if you ever right-sized the delivery system, you probably would need all that capacity. We have a variety of interventions running in the city of Camden. We've got outreach teams seeing high-cost patients. We've got massive amounts of data collection that's now coming in real time. We get a list of patients who are admitted to the 3 hospitals in real time. We use that list as our targeting list. We've got an intervention for the highest utilizers, kind of for the medium tier. Much of this is really about fixing primary care, which is a tremendous problem. Most primary care offices are understaffed. They are, sort of poorly run, poorly operational for what they're trying to achieve. The biggest problem that I've had is there's no business model for fixing healthcare. And in fact, I'm working against the status quo in that if I empty people out of the hospitals, that hurts the hospitals. So the hospitals make money on filling beds, and if I empty those beds out, that then works against their business model. The reason I've been able to do this in the city of Camden is that it's an adverse market share. No one's fighting over more Camden residents. If you scale this across the country, it becomes a huge problem. So one of the things we did is spend an enormous amount of time getting legislation passed in New Jersey that's somewhat modeled on pieces of the federal bill, which allows shared savings so that if I bend the cost curve in Camden by reducing ER and hospital use, that we can capture a portion of those savings back. So this bill was signed by Chris Christie. It was passed with wide bipartisan support, both Democrats and Republicans. There's no upfront money in this bill, so I have to capitalize this. But if we're able to bend the cost curve, we can capture a portion of those savings back. Our interventions are pretty straightforward interventions. We're looking at embedding nurse practitioners in small offices inside of high-cost buildings. We've done this in 1 building. We're looking at probably 5 outreach teams that are high utilizer teams, embedding nurse care coordinators into primary care offices, and getting offices to do something called open access scheduling, which is the same idea as just-in-time manufacturing, where you eliminate queuing because queuing in healthcare is very inefficient and very wasteful. So thank you very much for the chance to come and talk with all of you. That's our website. I encourage you to take a look at it.